The most common operation that's currently being undertaken in Australia, US and UK would be what's called the laparoscopic sleeve gastrectomy, or otherwise known as the tube gastrectomy. So that's where in effect your stomach is formed into a long narrow tube. It's wider than your esophagus, but essentially forms a long narrow tube from the esophagus down to the duodenum. So it restricts how much people can put in. There are also some hormonal changes that occur that affect people's desire to eat. Around about 70% of patients would be having a sleeve gastrectomy. So the less common option would be a laparoscopic gastric bypass, of which there are a number of those operations. The most commonly known is the Roux-en-Y gastric bypass. The bypass is an operation in which a small pouch is formed, and then the small intestine is joined to that pouch, so part of the stomach is actually bypassed. So it's like a road bypass in effect. So the food goes into that pouch and then directly into the small intestine. So it is a slightly more complex operation than the sleeve. It has slightly differing effects. And we have to be careful about which patients we choose to have bypass versus sleeve. But if, for example, a patient has reflux which is not controlled on medication, then they're better off having a gastric bypass rather than a sleeve. But there are multiple other factors, including whether these patients had any gastric intestinal metaplasia or dysplasia, whether they've had family history of gastric cancer, whether they have reflux. There are many things that we go through to help decide that choice.